Okay, this video is, does open heart surgery for coronary artery bypass or anesthesia cause brain damage? I'm going to go through this paper here, but I'm going to show you some of the things that are involved and how you can minimize the risks for yourself and for your family. Okay, so this painting right here is open heart bypass surgery. The initial picture shows you the arterial atherosclerotic plaques, the stenosis, means narrowing. So you got one here, like in the right coronary, you got another one here in the left anterior descending coronary artery. So this is a vein bypass graft taken from the leg, like greater saphenous vein. They'll often call it RSV, reversed saphenous vein graft, and they're going to initiate the blood inflows coming from the ascending thoracic aorta, and then the plug-in site is distally in the right coronary artery. Okay, so that's single vessel bypass right there. Now here's the second one. This is the left internal mammary artery, and they just reroute it down to the left anterior descending. So left internal mammary artery is called LIMA, L-I-M-A, to the LAD, left anterior descending artery. That's a typical, this would be a typical two-vessel bypass, okay? Here's a close-up of the atherosclerotic plaque, showing the stenosis there, the narrowing. We always say stenosis, a medical term. Okay, here is cardiac valve surgery. So this is the aortic valve. Left ventricle pumps blood into the ascending thoracic aorta. So this is the left side of the heart, and here's a mechanical heart valve. There's mechanical heart valves which require more anticoagulation, and there's tissue heart valves for replacement. Okay, here's a look at what the cardiopulmonary bypass is all about. You're going to take blood from the heart that's not oxygenated from the right side of the heart. You're going to bypass it through this machine which oxygenates it, the cardiopulmonary bypass machine, and then it's going to be returned to the arterial system. Okay. This is just showing you the clamp. So the ascending thoracic aorta gets clamped when the patient gets put on bypass, and that way they can work with the heart not moving so much. And they're going to put cardioplegia solution in there to slow down the beating of the heart. And this gives you an idea of some of the risk factors of, cardiac surgery. Okay, so now we're going to talk about this paper. You can look up this paper yourself on the internet. Just type it into your browser. Neurocognitive decline in cardiac surgery patients. What do we know? Author's name, Madigan Stanley. It's from the Journal of Cardiovascular and Thoracic Surgery from the year 2022. So here's what's interesting about it. About 45% of patients have some type of neurocognitive decline after surgery in the early postoperative phase. They typically recover often quite a lot, often quite back to normal. They're actually claiming that on average 45% have some type of diagnosable neurocognitive deficit post-op, but that only 2.5% persist at 3 months. To me, that sounds unreasonably high recovery rate. Don't get me wrong, a lot of them do recover, but I don't think it's that much. They say that at brain MRI, if you performed a brain MRI after cardiothoracic surgery, that 55% will have a new lesion on brain MRI. I can tell you, I look at brain MRIs every day. I almost never get a cardiac surgery patient sent to me. So they don't often have a symptomatic stroke in the early postoperative phase. They don't, okay? I can tell you my father had open heart surgery and he came out of it just fine. He had no cardiac, no cognitive deficit at all. One thing though I didn't like was in the postoperative phase, I stayed with him in the intensive care unit and they ran his blood pressure so low, like at around 90/60, I couldn't believe it, that I insisted on speaking to the anesthesiologist personally, and they said, oh, we run them low because, they can bleed at their anastomoses, the plug-in sites of the arterial grafts, and we don't want that to happen, so we run their pressure low. And I'm like, well, what about perfusing his brain? The reason we have blood pressure is to pump blood to the top of our brain, our cerebral cortex. So I was not too happy about that. But my dad came out of it fine. But, he was a physician. I think he was about 74 at the time. And he was probably about as healthy a patient as they ever get. A lot of these patients are train wrecks. So I would think they would not tolerate prolonged postoperative hypotension very well. Okay, it's very understandable. They even call it pump head, postoperative cognitive decline. There are a lot of risk factors, and you know what? It might be not at all have anything to do with the surgery. If the anesthesiologist is running prolonged hypotensive post-op, that could, be like the mouse equivalent cause brain damage. In addition, just the general anesthesia itself with the mitochondrial inhibitors, that can cause brain damage. If you damage the mitochondria in your brain, most of the time we think of it as being reversible, but sometimes stuff is not reversible. A lot of these anesthetics, the general anesthetics, damage mitochondria. The propofol is a mitochondrial inhibitor, which can be used in the in the intensive care unit. There's a lot of variables. If the patient has valve surgery, they're more likely to have a cognitive decline post-op, but it's also because you got longer cross-clamp time. Longer intubation times predict worse cognitive post-op outcomes. Microemboli from when you cross-clamp can be a problem. You can get microemboli shower down the kidneys as well, and then the kidneys release inflammatory chemicals. That's associated with worse cognitive decline. Intraoperative hypotension. We talked about prolonged pump times, kind of like prolonged intubation time. I talked about post-op hypotension, post-op congestive heart failure. Some patients go into CHF after the surgery. Some patients go into AFib after the surgery. It can drop the perfusion of the brain. Depends on your baseline risk factors. If they're hypertensive, diabetic, and atherosclerotic, which most of them are, that's why they're getting open heart surgery. If they add more heparin to the pump bypass tubing, you're going to have less blood sludge. That also lowers the risk. My father came out of the surgery fine. He was fine for 4 years. Then he was shoveling snow 4 years later, and he's kind of a hyper-energetic guy. And he's throwing the snow over his shoulder with wet snow, sticks to the shovel. You get that staccato motion. He dissected his left vertebral artery. He had a stroke, and then he had to retire. He couldn't practice after that. It was an embolism from the vert. I saw the early post-operative MRA, magnetic resonance arteriogram, and there were movement artifacts and stuff, and there was an occluded vessel. And then on the post-op, that vessel had opened up due to an embolus that had autolysed, meaning dissolved. So I think it led to his stroke that he wouldn't have had if he had otherwise. I had tried to make him go low-fat vegan then, but I didn't know enough. I sort of vaguely knew the Ornish diet. I didn't know about Esselstyn. I didn't know all the stuff that I know now. That was about 30 years ago. So anyways, it wasn't quite 30 years ago. It was about 25 years ago. Anyways, it was pretty sad. So what I'm trying to say is, if you just have coronary artery disease, why not just go low-fat vegan? Cure rate's about 100%. Cabbage, coronary artery bypass graft for open heart surgery for just atherosclerotic coronary artery disease. That doesn't increase your longevity, and you got all these potential problems. So we talked about that before. I'll talk some more about these anesthetics, because these general anesthetics, I think, are quite dangerous, more dangerous than people realize. Anyways, just something to be aware of.